So let's just start. So again, the brief overview is just to kind of get an understanding of what specific things can cause the visual dysfunction, how as therapists we are able to do some treatment and assessment, and then also when to refer out and know who to refer to. So essentially there is two systems. Our central focal system, which is the system that we're looking directly at, right? What we're looking at is what is it? And our peripheral ambient vision is what is around that area and where is it? So but they actually work together. And after some, any kind of like brain, central nervous system injury, those two systems become out of sync. So what can happen is that the brain will choose one or the other. So that's just one of the things that we want to be aware of as we're going forward. So things that I found, and this is just obviously very recently, as the journal indicates, it was of this year, is that I found this really interesting, and I think clinically I kind of thought this was true because I would witness this myself. So stroke survivors with prominent self-reported visual problems were more likely to experience fatigue. And why this is important is, say if you have a patient who is visually, like has visual issues and, you know, has weakness for walking or using their arm or anything else. The thing is that we're, as therapists and as the patient, they will tend to want to gravitate to things like the more physically obvious, like, oh, I want my hand to work, or oh, I want my leg to work. So I think what's important about this is that if we therapists actually address their vision, that can significantly reduce their fatigue and then give them more energy to actually impact their rehab overall. And I think by us kind of selling it that way instead of being, you know, just so focused on the physical part, because when we think about it, we only have one energy pot, and having one energy pot, usually our visual system and our vestibular system takes no energy. They work automatically. But after something like a stroke, it is very taxing on our energy system. And so the energy that would be reserved for thinking or cognition or healing is now being taken up by the visual system. And so if we can think about addressing the visual system as part of the whole rehabilitation, then it will actually give the energy back to the person to be able to probably achieve and have more energy for their physical disabilities that most patients feel like that's the more important thing to work on. Okay, so common ocular visual deficits. So it's broken up in columns where you can see that these are the defects and then the common symptoms that are reported, right? So we have patients that say, oh, like they're reporting the symptoms of, you know, double vision, or, you know, I'm just feeling tired, or nausea or dizziness, or light sensitivity. And these are the common deficits that can be related to it. So a lot of patients can have field cuts. So I think I just put more information on the slide just to kind of go through this. But, you know, this is what you can have. You know, the half of the field of vision, a quadrant, or basically all of it, all your peripheral gone and just your central, like, tunnel vision. And then, like, little spots of blindness throughout the field of vision. So another thing that can happen is cranial nerve damage. And so with so there's the three most important cranial nerves are 3, 4, and 6, right? And so this basically tells you when this happens, you know, you're going to have some type of double vision for sure. It depends on the direction of where the person is looking, but there is going to be that diplopia. And this is just saying what cranial nerve does for what. And so nystagmus is that if you ever had a patient where you see this kind of beating movement in their eye at rest, or it could be at the end of a movement, or at an extreme end of looking in a certain direction. It can be side to side, up, down, and also could be rotational, right? That is very, basically it's like, think about when you're watching a video and someone who has an unsteady hand and the camera is shaking a lot. That's what the person's seeing majority of the time, maybe all the time if it's a constant one. And that really can be disorienting and cause a lot of symptoms like nausea or wanting to vomit or fatigue, a lot of fatigue, and not being able to kind of ambulate. Okay, so visual processing impairments also. So this is more of things to do with the occipital lobe and the temporal parietal lobe. So visual processing doesn't just happen in the occipital lobe. It happens in a complex of things. And so it involves different parts of the brain to kind of understand what's going on. So it's like your eyes gather in the proper information, and once it's gathered, your brain has to sort out what to do with it. And so what can happen with the stroke are certain things like visual agnosia, when people can't recognize objects and or faces. Visual neglect. So there's basically two types of neglect. There's the egocentric, where you're ignoring things that are on one side, and then there's from the person's point of view, right? So if it was me, it would be my point of view, everything, say, on my right side, I'm not paying attention to. And then there's the allocentric, which is no matter where the object is, you will not see one side of that object. Visual perceptual impairments, so things like discrimination, memory, sequential memory, figure ground, form consistency, closure, and spatial relationships. We will go through those a little bit later, but those are also important for functional tasks in our day-to-day. So another thing is ocular motor dysfunction, which is something that I'm going to take you through on how to assess, and then some treatment ideas. So pursuits, tracking, which is tracking. Saccades is basically targeting. Accommodation is each eye has the ability to see clear at any distance, right? Fixation, being able to look at something as long as you want. Convergence is your eyes teaming up. Stereopsis is 3D vision, which is important to depth perception. And then that integration of what we were talking about earlier, of the central peripheral vision, how it works. I will be honest, I can no longer see the chat in my presentation, so I don't know if someone's asking a question. Connie, are you still there? No. Okay. So what I'll do is, if you want to save your questions at the end, we'll run through it. And also when we do some of the exercises, you can ask questions there, if that's okay. Okay, so this is a very specific on thalamic stroke. So where are the areas of location for thalamus, and then the things that can actually happen when there is a stroke at the thalamic area. So as we know, the thalamic area is like our central relay station. So what they've found when there is kind of like isolated strokes in these specific parts of the lambic, these things can happen. So, and we'll go through this. So, like loss of convergence, loss of being able to I-team, not being able to target, which is a saccadic activity, not being able to track smoothly, voluntary motor actions and arousal. So it's just like basically unable to kind of stay awake or can't even like pay attention with their eyes. Pseudoabduction palsy. So basically it's like a cranial nerve issue, but there's nothing actually organically attacking the cranial nerve that's causing this inability to abduct the eye. And then so hypermetric saccades, that just basically means that you are overshooting the targets. And Horner syndrome, so it's like one eye gets bigger, and then the diplopia. So, and we'll talk about that a little more. Diplopia can happen either in a vertical plane, a horizontal plane, or even in a diagonal plane. Okay, so these are the things that I highly recommend that we need to use our neuro-optometrists or neuro-ophthalmologists. And so what are those? Those are, a neuro-optometrist is an eye doctor that has specialized in neuro-optometry. So they can prescribe lenses and light therapy, which we'll talk about down there. And a neuro-ophthalmologist basically is an ophthalmologist, a medical doctor who has studied the neurological side. They can read the MRI and tell the person, what's going on. They can treat the disease. And so when certain things like cranial nerve palsies happen and causing the diplopia, what needs to happen is rehab is going to not be as effective. Because there's sometimes the palsies will resolve itself. Sometimes we just need something like a prism, which is going to just give them that opportunity to realign the eye. And so the person, it will eliminate the double vision. And then we could do rehab with them. Because once they're able to see one image, we as therapists have a better chance to actually try to get them to maybe even get away from the prism as they start to heal, and as the palsy, if the palsy has the opportunity to heal, right? And sometimes prism lenses can't work at all, so then they'll need surgery. And so they'll be able to determine, but basically what they do with the surgery is they try to take, they figure out if there's one muscle that's a little bit longer or shorter, and then just like pull and place it in a way where the ocular is aligned up again. The other thing that can help is with the field cut, you can also have them have peripheral prisms, which kind of expand the visual field. And from my experience, we have low vision doctors here that could do that, where it's about 5
Sorry to interrupt. Your slide missing. Your presentation slide accidentally gone missing.
Oh, it's not on the screen anymore?
No, not on screen anymore. Could you please help?
Okay.
Put it back. Thank you.
Okay, I don't know why that did that. Okay, let me share it again. Okay, is it there now?
Yes. Thank you very much. Thanks.
I'm sorry. It on my end, I can see that it's okay.
But it is on the not yet on the presentation mode. Could you please?
It's not on the presentation board.
Full screen, yeah. Full screen, please.
Is that better?
Not yet. It still show like.
Dr. Wanapa, every time she would put it on the slideshow as full, it would go black on us. So that's why we were leaving it like this.
Want me to try? I'll try again, and we'll see.
Okay.
Is that?
If you hit from current slide on the second row. If you go to the second row, it goes on the left. It says from beginning, from current slide. If you hit,
yeah, it's going black again.
Yeah. Oh, there it goes.
It went. Yeah, last time it went black. Okay, so it's there now, right? Okay, good. And so with the expanding prisms, patients can gain about 5 to 10 degrees of where their field cut, into where their field cut was. And it actually can help a lot with people navigating. And there's also, well, at the end, we'll talk more. There are things that research has shown that can, showing promise that can help with field cuts. And then the next thing is the nystagmus. So really, therapy can't do anything about that. It has to have, this is where the neuro-ophthalmology is important. And if you don't have neuro-ophthalmology, then at least like a neurologist consulting with an ophthalmologist would be probably the best. So things like gabapentin, baclofen, clemizepine, those are the main drugs that neuro-ophthalmology will prescribe to help dampen the nystagmus. And from my experience with the neuro-ophthalmologists that we work with, they usually start with gabapentin and then tell them to keep going up little by little by little to see where it can find that optimal point of, because sometimes you can eliminate the nystagmus or at least decrease the nystagmus to a point where it's where the brain can actually ignore the smaller movement. Unfortunately, these medications also can have side effects like being really sleepy or like fatigued, or just like they're, as you know, they're used for other things like decreasing muscle tone. So it is going to be it needs to be a balance. And so the thing with the photophobia is, and I don't know if it's in Thailand, but here we have neurooptometry, which they do light therapy. And so basically the neurooptometrist will assess people's ability to tolerate the different spectrum of light. So really, when people are photophobic, they're not just it's not all light. It's usually a certain spectrum of the light that is causing some of that fatigue. So the theory behind light therapy is that because when we shine a light in our eye, our pupils are supposed to contract and hold depending on the frequency of the light and if it's at a consistent level. And so after something like a stroke, their pupils are not able to sustain that, and so they tend to fluctuate and open. And then when there's too much light coming in to our eyes, that can cause more fatigue and sometimes an autonomic reaction. So with the neurooptometry and the light therapy, they figure out what spectrum the patient is more sensitive to. They prescribe certain color lenses and a light box. We don't have it here, so we have to refer out. And usually they prescribe it for like 5 times a week for like the typical is 4 to 6 weeks, and then they see how they improve, and it's usually like 5 to 20 minutes a day, 5 days a week, and it actually has been quite helpful in helping people with their light sensitivity and fatigue. Okay, so we're going to go through the evaluation of what we can do with the ocular parts. So with the pupils, if you have a pen light that is a non-LED pen light, you would just have someone look straight ahead, cover one eye, and then you would just shine the light straight ahead for 10 seconds to kind of just have them see how their pupils are reacting, if they contract, if they open, close, kind of thing. So this is just what we're going to be going through, and if you want time, we can actually go through each one and how to do. I know we probably don't have the pen light, which is fine. And so we talked about the pupil, check the symmetry, size, contraction, eyelids, right? If there's any kind of like drooping, and head position. So head and eye position are very, very important because some people might say that they don't see double, and really what's happening is that they're adjusting their eyes or their head to eliminate that. And once you align them, then all of a sudden things get blurry or superimposed or double. Okay, so for this one, for the ocular motility, I actually want, if you can, pair up, because what you're going to do is, this is a good screen for, I do this quick screen for cranial nerves, just to see if you can, if people can move their eyes. So basically, you're just going into every direction. So looking up, center, looking down, center, to the left, center, right, center, and then up to the corners, always returning back to center. And so that will tell you if there's cranial nerve issues, but also it will tell you if the patient is symptomatic. So sometimes when people do this, they can feel really dizzy, they can feel eye strain, fatigue, nausea, and increase of headache. So I want to have some time for you to do some of that, and let me know when you're done. Okay. Good to move on? Okay, so for pursuits, gotta get my little, so for the pursuits is just tracking in a smooth manner. So you want to be about 3 feet away from the patient, and they want to maintain the focus of a letter, right, on a stick usually, like this. Let me see. When I
can see you too.
Okay, so you can see when I'm doing like stuff with the stick, right?
Yeah.
Okay.
Yes.
And so, right, so what you're going to do is, right, if you're with the person, say if you were about 3 feet away, I would be trying to have them follow the target, right, up and down. I like to do diagonals too, and circular motions, right? And so you do that. While you're doing that, what you're looking for is you're looking to see if the eyes are able to move smoothly together, if there's jerking or freezing, or if there's mild skipping or jumping. And also just you're trying to get what symptoms it may be provoking. Do you want to try? Or is there any supplies? Okay, so I'll just move on. And then so saccades is the targeting, right? So we use saccades for everything. So when we enter a room, our eyes naturally target everything that is in the room, just so it helps us understand the layout of the environment. And so basically, you're going to be having a target. Again, your targets are 3 feet away from the patient, and you're going to have them look. And it could be a little bit more easier, like just erase 2 pens or 2 marker heads like this, and you have them looking back and forth, right? They're supposed to keep their head still with all of these. And then diagonals are helpful as well, and then up and down as well. Again, so what you're looking for is you want to make sure that the person is able to land on the target, so not overshoot or undershoot, and that there's no delay. Sometimes you'll see someone move to a target, but then there's this weird movement to the target. You want to note all those things. And again, symptoms to see what it feels like. So there is a very standardized test for saccades, and it's called the Adult Developmental Eye Movement Test. And so what it is, I sent a copy of it so you can have it yourself. Basically, it's a standardized test that has the reading norms of ages 14 to 68. Again, what you do is the test plate, so reading up and down. So the person would read this continuously from here to here, and then you time it, put the score down here to here, right? Time that score, and then when they read this one, they have to read from here to here. So, and then put that score down, and then the score of the horizontal time is then divided by the total vertical time, and then you would get their ratio and their standard deviation, and see where they are in the norm. So the one thing that I find that's tricky about this is that the person might be within the ratio mean, but just because the ratio and the horizontal are where they should be, but the times of their vertical and the horizontal maybe even the double of what should be standard. So then that still indicates that this person is having dysfunction. And this actually is really great for more for things like when people are having issues reading, right? This actually shows that reading can be impacted by this. And reading, actually, in general, there's 3 things visual things that we need for reading is the pursuits, the saccades, and fixation, which we'll talk about fixation. Okay, so these are just terms about, eye position. And then, so convergence and what is divergence, right? So being able to track something that's coming in, and then being able to have outward movement towards something that's moving away. Okay, so for this one, we need there's this stick. Where's the stick? So you need a 14 font size letter. right? This was not 14 font. And so what you would do is you'd have the patient hold the stick, because you would need a measuring tape. So they would hold the stick and then they would bring it in. And when you would see either their eyes deviate from where they should be instead of the tracking in, or if they say, oh, I see double now, you'd have them to stop. Then you would measure the distance from here to here, and then you'd get them to pull it away to see if, when they report, they see single again, or when you notice their eyes are starting to track together smoothly out, and then you would have them to stop and then measure that distance. You would do it 3 times. I think just more for averages, and also it's a way to see if they're, by doing it, that they're able to have, their brain is able to learn to work better together, or if they have more fatigue and less endurance. So this is actually used for research. It's a near-point rule. It's also called the accommodation in R50 rule. And so what it does is you will place it on the tip in between your eyes, and you would slide the board with the letters on it. And once it turns into 2 double, that would be their breaking point. And then you'd pull it away and it turns back to 1. That would be their breaking point. We here tend to use this more as our standard of practice, just because this is the most research item for near point rule for convergence when you have seen in the literature. And so accommodation, so again, what that is ability for each eye to see clearly. So it's like when you look far away, your eyes relax, your pupils relax. When you look up close, your pupils contract. So with this, there's 2 ways of doing it. So you definitely, it's each eye alone. You definitely want to, you can have them pick 2 items and then watch them look at one item and look far away on the other item, and then see their eyes contract. One thing that I like to do with this one is I have like a bar chart like this on the wall, and then I have like something like this up close to them. And so when I have that, I tell them to keep their head still, and I ask them to look at the close one and then look at the far one. And what I can tell is from them telling me, were you able to see it clear? Sometimes they're like, yeah, it's clear. However, I have to explain to them that, so whenever we open our phones and we put on our camera, usually a camera is a little bit blurry and then it's sharp. Our eyes are better than that. So it should be instantly sharp. So when I'm doing this test, I let them know that, and then they're able to tell me if they're having trouble seeing it clear, close, or far. Another thing about that is this one's really hard because there may be some acuity issues. Some people who they haven't gone to the eye doctor for years, and so this is where it's hard to figure out, like, is this accommodation or is this acuity? And so how I kind of tease that out is when I'm asking them and they're like, oh, it's really, really blurry far away, I can't get it. I tell them, I'm like, okay, can you sharpen the object any more than you can? And if they can, usually that's a good sign that it is accommodation. It doesn't completely rule out that there's acuity issues, but it means that if they can work on that, then they're able to try to get their brain to engage to let their pupil contract and relax enough to see clear at that distance. Stereopsis is 3D vision, and 3D vision is important for depth perception. It plays a role in depth perception. So we have, in our brains, we have what's called stereo cells. And stereo cells, they turn on only with 3D images. And so why this is important is because things like, there's a standard, in America, there's a standard of stereopsis test where you have to have 5 out of 10 in order to be able to drive. And that's a standard. What's difficult with this also is that some people do not have, we don't test this before. So you just ask people, historically, were you able to see 3D movies? And if they say no, or yes, but it really made me sick, then at least I kind of know where they're at. If they say no, then I already know that it's impaired. And testing this, it's not going to be helpful information because they didn't have stereopsis before and they were living fine. It's not like the stroke impaired their stereopsis. Okay, so fixation is the ability to look at things for 3 seconds at least, the minimum of 3 seconds. And so for this one, I pick, usually a letter and just have them stare at it, and I put it in different areas to see if they can keep their eye on it without looking away. And so, like as I said before, 3 things that we need visually for reading is saccades, smooth pursuits, and fixation. And so those things for reading is being able to move smoothly across the line, be able to target each word as you go along, and also being able to fixate long enough on the word for your brain to actually comprehend it. Okay, so functional scan. So this is kind of what I just talked about with this 3 things. So we here do something like the alphabet. So we want to reduce the amount of comprehensive or cognitive load. Usually the alphabet is something that is familiar with a lot of people. Sometimes we do numbers if there's language issue, just because it's easier, or sometimes we do, for this functional scan, do something that's more like shapes. And so the point of this is just to kind of see how people's brain, how they're processing the vision that they're actually trying to use. And so this has a standard, it's 60 seconds and less would be the normal for this. Also, I think I sent some of these to you, and the smaller it gets, the more difficult it gets. So we use the larger ones first and then the smaller ones later for assessment, for like reassessment. Okay, so contrast sensitivity. This is important for things like night driving, or just navigating in low light areas. So when people get up to go to the bathroom at night, if they can't see that well, because of the contrast sensitivity. So this is a very standard test. You need to be able, it's 1 eye each. You need to, you record them reading the lowest line that they can read. If they can get 3 of them correct, then that's where you would get it. You would need a light that's like 80 lumens to do this as well. But it's important just for, especially if people want to get back to driving, and that's usually one of the most important things people want to do, even after a stroke. But it's definitely, this is something that needs to be assessed. Okay, so field of vision, basically, you're able to just kind of cover 1 eye and then just have them use either, you can use, a finger, classically it's finger, or how many fingers am I holding up kind of thing. And then you would do it vertically and horizontally for each eye alone, and I put down the limits there as well. So peripheral vision, same thing as a field test, but when you do hold up numbers or letters, can they read them? And so one of the quickest way I just do peripheral vision is I just ask them when they're looking directly at me, if they can, everything around me they see, is it clear or is it blurry? So that's usually a quick way of doing it. But also you can just have them look at a chart like this and then have them stare at one letter, and then as they're staring at one letter, can they read any of the letters around it, and is it sharp? Okay, so things that we can do, occupational therapy-wise. So vision exercises versus compensation, modify the environment.
Roseanne?
Yes?
Sorry, there's 2 questions about testing real quick.
Okay.
What test can be used for ages over 70?
Ages over 70. You mean so basically for not the adult developmental eye movement, or just specifically?
Could that one be used for people over 70?
This one, no, because it's 68, but everything else you can do. This is one of the standardized tests for SICADs, but you can do the other SICAD testing, which is part of the VOMS, which is very standardized, and there's lots of good research on that too. So you can just use that instead. But everything that I've shown you today, you can use on like ages besides this one. Like from child to elderly.
Perfect. And then during the testing, can the patient wear their glasses if they normally wear glasses?
Yes, definitely. If they wear glasses normally, we are not testing their acuity. That is something that we cannot change because we are therapists. And definitely, if they don't have glasses and they need them, it's really going to make it harder for you to be able to see if it's the acuity versus what their brain is not telling how their eyes how to move. Especially if you're doing the stereopsis. If they need glasses to do the stereopsis, like anything where it's like mid-distance or reading glasses, they need to have that, or they're not going to see the stereopsis at all. They're going to automatically fail it. That's a good, and it reminds me of another thing is some of these testing can be tricky if someone has progressive lenses, right? And so a progressive lens is, as many of you know, are lenses that you can see at any distance clearly. They're kind of designed like, I'm going to draw them. So I'm going to draw it to a picture. So if this is the lens, okay. So if this is the lens, right? They're all progressive, but this part here is designed for like mid-distance and close, right? So what's hard about that then is you have to have the person try to position their eyes to, if you're doing something like closer versus farther, right? And so that's a little trickier, and it gets easier the more you practice it. But if you're aware of, saying like for the stick that I was doing, the targeting, or like not targeting, the tracking, if I do a progressive lens and I'm doing this with them, it's going to get blurry. They're not going to be able to see this. So I will either have them take their glasses off and be like, is this a big enough target for you to see? Then that's better than them trying to struggle with their progressive lens. Or if they have reading glasses, I rather them just have reading glasses on for any up close, like mid-distance, close kind of assessment and during treatment as well. And so it does get also hard when you're testing the accommodation, right? So it's like they have to figure out, so I have to put something in, if they have a progressive lens, where they could see, say like this, in their up close, and then I have to figure out the distance where I could put this chart high, low, enough where they just shift their eye and look out at a different part of their lens where this can be as clear as possible, right? And so once I get that kind of positioned, then when they look back and forth, I will know if there's a delay, that's going to be more of the accommodation and not the acuity. Is there any other more questions?
No, that's it.
Okay. Yes, and Connie, just interrupt me anytime while I'm doing this, because I can't see the chat. Okay. So as therapists, we can modify the environment, and so just being able to help maximize the environment at home or at work if they're returning to work, and with things like light, making sure paths are clear, contrast colors if needed be. And so also we talked about this a little bit earlier, behavior and mindfulness, meaning pacing. So part of it is that you're fatigued. So regardless of a stroke or any condition, when we get fatigued, normally our vision is one of the systems that take a hit. So our eyes get blurry, we can't see. So if you have a stroke and vision is impaired, when the person gets tired, their vision is going to be more impaired. So we have to be able to help people learn to not just burn through their day and then just have worse vision and can't function. Also things like school and work accommodation for vision, and we can talk about that in a discussion later. So compensatory things that you can do as therapists. So we talked about like sending someone to the neurooptometrist for prisms or the ocular surgery, but that's not instant, right? So what we need to do is you can take, if they have glasses already, or if they don't, you can get fashion glasses. So what I like to do, I have a pair of glasses here, is if someone has double vision, we want to make sure that they don't just put a patch on. Like that's a very old school way of thinking. It's like, oh, we put a patch and then you can alternate patches side to side so one eye doesn't get weaker kind of thing. We don't like doing that now because what can happen is that it blocks the light from coming in for your peripheral vision. So again, there's that central vision, which is what you're looking at, and there's a peripheral vision, where is it, right? So what and where. The thing is, when people have double vision, they see two images, but their peripheral vision is intact. So we don't want to impair the peripheral vision. And the less light that's coming in, it actually affects the size of the rods and cones in our eyes, and we don't want that either. Because when you actually get to use the eyes again, we don't want anything to atrophy. So you can put like some tape. You can even use like this type of tape, right? Because what's great about just standard tape is that it has this nice like semi-translucent. There are like 3M tapes too, that are paper tapes, or the more of that like translucent tape that can be helpful. So what is spot patching is basically if someone's wearing glasses like this, I will see which eye is more affected, and then I will go to that eye and I will put my finger in front and I will say, okay, tell me when you don't see double anymore. And when they tell me, like, here, I don't see double anymore. So I take that off and I just basically make it nicer than this, but I basically do this. So what that does is it helps them still be able to use their peripheral vision and also they feel like they can see better. Sometimes it's like they can't, if their diplopia is so severe, I will just patch the whole side with that translucent tape. Contrast sensitivity, and so the compensation for that is things like increasing the light. So we don't want to increase glare, as glare is just so, it's basically too much light, then you can't see anything. So directions that are best are from behind and from the side. So those are the best directions. So things like, if you know that our patient gets up in the middle of the night, they have a neurogenic bladder and from the stroke and they need to go to the bathroom, they're not going to turn on their light. And so what can happen is that you can at least have some motion censored lights that can help. So then they're able to see the ground or when they are walking. Things like yellow filter or anti-reflective coating can help contrast for patients. And then this, again, something that this is where the optometrist and the ophthalmologist can help out. Custom wavelength lenses, and they can sometimes improve the contrast sensitivity for night vision. So I've had some neuro-optometrists use that for people for nighttime driving, or even if people like to go for night walks. Okay, so I know we said with cranial palsies, we do send to the neuro-optometrist. But if it's incomplete, what you can do as a therapist is have them kind of tap, right? And so if someone was having trouble moving their eyes over to my right, I would have them try to move their eyes and then I would tap. So why we're doing this is because the muscles around our eyes are just like any other muscles, right? They will respond to, for example, when I'm treating someone with a hemiplegic arm and I want them to isolate, say, extensors, I want them to move this so I can get them to do wrist extension, I'm going to tap this while they're doing it because that's going to help their brain understand that feedback of that this is the muscle that needs to be moved. And so that's what we do here. If you want to try to get someone to move in a certain direction, you just tap the muscle around that area as they're trying to go in that direction. It's getting the brain's attention. And so the pursuits, you could have a coin or a letter like this. And so what you can do is just have them focus on this, and you're looking to make sure that their eyes are moving smooth and together. So the goal is to always make sure that whatever the patient is looking at is clear and sharp when it's still. If the patient's I can't get it clear, it could be acuity reasons or that they're
Did we lose Roseanne?
Yeah, I think we lost her.
Oh no.
So it's sharp.
Roseanne, we had lost, there you are. We had lost you for a minute.
Okay. Okay, so where did you leave off?
Oh, we just lost you for a few minutes.
Okay, so do I need to go back?
No, I think we're good.
Okay. Okay, so if it is something like if the person's having double vision or super imposition, I will do each eye alone for this exercise. What will happen is the goal is you want them to see whatever you're having them stare at clearly as possible. If they can get it sharp and clear, great. If they can't, as long as it stays that same level of sharp and clear as they can get it as it's moving, that's what's important. So the goal is you want them to be able to have that ability to see whatever you're seeing is clear, but as it's moving. So the goal is to actually have it moving quite fast, right? If they can't do that, if it's just like you notice that their eyes are jolting around or it makes them really sick, then you need to go slower. They need to go slower. Sometimes they can do it themselves, which is easier because you know where your hand's going to go because you're thinking of it, right? And maybe that's where they need to start. And then as they get better, you would progress it where someone else is holding it. So then they don't know where it's going to go. As they get better, then we use something like a background that is symmetrical and pattern, and then moving it, having them to do that, right? Because that is then having them try to focus and track something in a busy background, which we do all the time in our functional lives. Now, do you have this stick, or do you want to try that with each other? Yes, no, or do you want me just to continue?
I think they want you to show. Can you take your slides down so they can really see you?
Okay.
And then I think we're over time. Do you know how much longer?
Yeah. You know what? I will. Okay. I'll be just like to 6:30.
All right.
I'll go really quick.
Okay.
I know I purposely did a lot of slides so you can have it as a reference, because the thing is that it's such a large topic and it's really hard to do it, I think, this way, because the hands-on, so when I've done it in the past, when people come here, it's easier to actually interact and actually just do all the stuff, and that's where I think it's easier. So can you see this now, right? Yeah. So basically you want to make sure that the person is following this with their eyes and keeping their head still. You want to make it them to have it as sharp and clear. Once they're able to do that by themselves, then you can have someone else move the stick. And once they're able to do that, then you can have something like a pattern background like this, because then that is more functional. So tracking in a busy background. Okay, let's go back. Okay, so this is where you can jump back and forth. Actually, what's good about this is this, for Sagat, I'm going to show you the eye movements. So you see that chart on the screen, and then you see those red zigzag lines. That's the movement of the eye for this exercise. So it's jumping. The top one is column jumping, and the bottom one is vertical jumping, row jumping. So what that does is it helps train the ability to control where their eyes want to be in a busy environment, just like you would functionally. And so what we don't want people to do is cheat. So instead of like counting, saying like oh, 2 in, and then that's the letter I'm going to look at, and then jump and count in 2 in, oh, that's the letter I'm going to say. You want them to attempt to do this zigzag pattern to help with their ability to learn to control their eyes. Okay, and so this is the Brock string, which is, I sent a picture of for you to have, to use. And so this is actually one of the most powerful exercises you can have, because it does work on convergence, but it also works on our central peripheral and also a bit of our accommodation. So our accommodation is actually an essential building block for convergence. And so what this does is when you look, you hold the string up to the nose. So I'm going to do a demonstration of this. Hold on, let me get my string out. Okay, I'll take away the screen. Okay, so you have a string, right? It's going to be about 10 feet long, right? It's very long. You got some beads. I'm going to just, you would tie the string one end to the doorknob or a chair, right? And then the other person, the patient, would hold it up like this. So I'm just going to use a short version of it so you can see, right? So it's going to look like this, okay? And so when I look at a bead, I should see that X pattern that you saw on the screen. So any bead that they look at is one bead, and everything else is 2. And so that actually happens in our brain. It's called, anytime we look at one thing, our eyes converge on it, and everything in the background is double. The reason why we don't see it like that in the world is because it's too confusing. So we have something in our brain called suspension, and that turns on, and that takes away the double in the background. So the power, this exercise actually will show if people are having their eyes truly team up, because it eliminates the suspension. And so I tend to show people this picture, which I'm going to go back to on. Because what is quite amazing is that people will, once they see this picture and understand this is what they're supposed to see, that helps their brain, their imagery part, know that's what they want to see, and helps their brain actually try to see this, right? And so this is the ideal. Sometimes people will say, I see one string and I see one string going in and 2 strings going out, or vice versa, or they only see 1 string. So if that's happening, there's some suppression going on, meaning that your brain is not intaking the information from both left and right eyes. Even though their eyes are open, the brain is not taking and integrating the information. So this exercise is important to try to override that suppression, because this is so important for things like depth perception, right? For walking, for reaching out, for things for grabbing, anything. And so one of the things I have people do if they are having trouble is I have them, with the string, I have them close one eye versus the other eye when the string is on their nose to tell me if the string shifts left or right, if they're seeing a single string. And if it shifts, then I know that when it shifted over, that's the eye that's being suppressed. So then I will tell them to then the eye that's being suppressed, I tell them to keep it open and close the other eye while looking at the string and bead, the one bead. And then I'll have them slowly reveal the other eye, and that will sometimes help the brain not to be suppressing the information from the eye that's being suppressed. Sometimes blinking really quickly can also help decrease the suppression. And then I sent a picture of some glasses and I'll show, Wait, can you see these now? Can you see the glasses? They're red and green glasses. They're anti-suppression glasses. They can help when you put them on because it's extra information for the brain to know that there is whatever you're seeing from one eye should be one color, and the information from the other eye should be another color. And that's an extra tool for your brain to be like, oh, logically, you should be seeing a red string and a green string going into whatever color bead, which usually turns black, and then two different colored strings going away. So that also is a thing to help with the anti-suppression. What can also happen with this exercise is that you may need to, people may be overcrossing or undercrossing. So what does that mean? That when they're looking, they're not seeing this X, they're seeing an X pattern, but their X pattern is starting in front of the bead that they're looking at or behind the bead that they're looking at. And so the hint that I tell people is I tell them that to imagine that there is a bug crawling towards the bead from where the X is, and it's splitting the string behind it towards the bead. Most of the time that works. Sometimes people will see this and they will see an X pattern, but they'll also see two beads that they're staring at. And so what I tell them is I want them to imagine that there's like something like an animal crushing the two beads together, or that I tell people that I want you to imagine that there's magnets pulling the two beads that you're looking at together to kind of help get the eye teaming. So these are other ones that I use for convergence, and they're pretty self-explanatory. And I think like if you have questions, Connie has my email and you can email me about these, but they're pretty self-explanatory. Or maybe we could have like pictures later on because there's just so much to go through. So accommodation, I think we talked about it, is like you basically want to have each eye being able to see clearly at any distance. So the easiest thing is I have people just pick two objects, something close, something far, and cover one eye and really try to see that object clearly close and then target far away and see that other object clearly. And so that's really working that contraction of your eye up close, right? And relaxing your eye far away, which needs to be able to happen quickly.
Another question.
Uh-huh.
How about the color bead test if the patient has color blindness?
Yeah, so those Ashura tests, we actually don't do that much in the sense of when it comes to that, we leave that to the optometrist, color blindness. There is some apps in the app, some apps that kind of test color blindness, but really color blindness is something that we leave to the optometrist. Does that, I know it kind of it doesn't really answer your question because we don't really address it that much. I mean, from that point on, it would be more like accommodations. And if someone was colorblind prior, then really we don't do anything about it. And we usually use the recommendation of the optometrist after. I mean, sometimes if you have the ability if they have the ability to learn, like this is orange and then you have like red, and if that's where they're kind of colorblind, you can try to remediate and say, okay, this is what red is, this is what orange is, but sometimes it can be quite difficult. There's no guarantees. So we usually just leave it up to the neurooptometrist or the optometrist. Okay, so with the stereopsis, there are things that we can work on. They're called vectograms. And so they look all weird, but if you had the red and green glasses and you put them on, they will then turn into 3D images that jump out. And so that's a great way to try to help turn on those stereo cells, because there's nothing that we can do but expose the person's brain to this for stereo, to turn on the stereo cells for the 3D images. And it's actually really important to try to help eliminate the diplopia first before you even start using the stereopsis, because it's very, very challenging to remediate the stereopsis if there is diplopia. And these things you actually have to buy from a place like Brunel's, which is like a vision rehab place, and they are quite expensive. So we only have one here in the clinic. So for fixation, I usually just have, and I will stop sharing the screen here. So I will usually have something like two different colored markers. So I'm going to call this, so orange and blue. And so what I tell the person is stare at the color and only stare at it until I say the other color. So I say orange, and then I'll just move this marker, and then I'll say blue. And so I'm looking at their eyes, making sure that they're looking continuously at the color I've called, orange. And then I can mix it up where I'll say blue, orange, blue, orange. And then I can vary this, how quickly I change the colors. And then you can see for like endurance, how long they can tolerate fixating. Okay. So functional scan. So I think I sent some things. So things like, this is a good example of finding words in a sentence, right? And so that's a good way to see if the brain is actually comprehending and seeing what is being written instead of just kind of jumping all around. Also can be done through things like letter scans, or even like things like stars, crossing out pairs. And that's usually more for reading. So the one thing that therapists we can do, I know we talked about the light therapy for the neurooptometrist, is pupil stimulation. So pupil stimulation is one thing we can actually do. I don't have my pen light, so I'm going to show you what it would be like if I had my pen light. So basically, you're going to cover one eye, and you're going to have the person look straight ahead, and you're going to shine a light, a non-LED light, at an angle, at a 45-degree angle, for 15 seconds in each angle, and then straight ahead. And so that, and then they would do it to the opposite side. That is a homework that people can do, and I tell them to do it before bed because it can give them a headache. And that will help train the pupil to learn to sustain the contraction in a consistent light when you're having in all different directions. Because light photophobia is not just straight ahead. You know, a lot of people will wear like sunglasses or hats, but it can come at any angles. And by doing that, that actually can help. That's something that we can have people do if they don't have access to the light therapy. At least it can help reduce some of that.
Roseanne?
Yes.
We have 2 minutes.
Okay.
Maybe, do you want to just do a couple and then just see if there's any question?
Why don't I just have questions? Because I think that might be just better. So questions.
Do you want to unmute if you have questions?
ครับผมทีม OT ที่ไหนมีคำถามเพิ่มเติมไหมครับ สามารถพิมพ์เข้ามาได้หรือว่าจะพูดภาษาไทยก็ได้นะครับหรือพิมพ์ภาษาไทยมาก็ได้เดี๋ยวทางเราช่วยแปลให้ครับขอบคุณครับ I speak in Thai that ask everybody they can write in Thai or speak in Thai we translate to you okay thank you
Yeah, and they can also send questions through U-Ton, and we can get them to Roseanne.
Yeah, I mean, I knew this was going to be, this is a monster topic. That's why the slideshow that I sent to you is 75 slides long. And I think like if you read those and then have some questions, I'm pretty sure that Connie can send it to me and then I'll be able to give you some more information about it. It's just a very complex and not taught a lot of vision really. So I didn't really learn about vision so I've been practicing for 20 years now, and it was in my like 9th year of practicing is when I started realizing how important vision was, and I started learning about it and how it can impact everything. Okay, so what are the recommended reps for each exercises? Should patients carry on exercise?
A question in Thai. They want to know the treatment in the children 3 months who have the scene 3 palsy, both of the eye.
Okay, and so when it's something like an infant or child, so the visual development of children from, I think it's like from 0 to 14, there are certain milestones where they can't do certain things, like saccades is going to be hard for them at a certain age. So when it comes to that, the nerve palsy in an infant, I mean, I think part of it it depends on the source. Like, is it like from like a congenital defect? It was, or is it full palsy or is it partial? I mean, one of the things is, and how old is this infant?
It's 3 months.
3 months.
3 months. So, at this point for 3 months, as therapists, we can't really do anything. I mean, the only thing you could do is, the tapping that I talked about, where you can tap the corners. You want to be obviously gentle because it's a baby and not poke their eye, but in the direction, but also just like seeing if they can just have them track into that area. But if they're 3 months, they're not going to be able to even really track. So at this point, it would be more of like see and wait. There's one question. Are there any recommended reps for each exercises? Should a patient carry on the exercise if it triggers dizziness? Okay, so that's actually a really good question. So reps, I have people try to do it at least once a day. If they can, do it twice a day. And most of these have some time limits. So the tracking one has like 15 seconds, working up to 15 seconds or 30 seconds. The Brock string is 1 minute total, the whole exercise. The rest is more like, can you do as tolerated? Can you do this whole sheet kind of thing? If they can, and it triggers things like dizziness, what we want is we want to trigger some type of symptoms. So because that is actually replicating what they're feeling in their functional day-to-day life. And so what we want, though, is to trigger that symptoms up to 4 out of 10 on a scale. If we go above 4 out of 10, then it's harder to manage the symptom and they'll need more rest time. So we have a rule here. It's like 4 out of 10. You get to 4 out of 10, stop the exercise. If you need to close your eyes, or if they need to like eat something or drink something or just rest for a bit to bring their symptoms down, or do some deep breathing to once they're around like 1 or 2, then they should go back to the exercise, right? So that is the rule that we want, because we are getting to what is distressing them, right? And that's what's going to help them get better.
Sam, I hate to stop, but everybody has to get to work. It is 8 o'clock in the morning there, and their bosses are all going to be very upset.
I apologize. I'm sorry.
No, we should have made this a 4-hour topic, like 2 sessions of 2 hours. And I think that we need to bring some people over to train with you.
Or I can go to Thailand.
That's right.
I love Thailand. I would do that. I would come over to Thailand too, because it is a very hands-on experience, and we just need to it's easier if you're there and I'm there to kind of help explain, and then you can see how to do the exercises, how to do the assessments.
I think that's a great idea. Dr. Sushila, Thailand.